Let's welcome them to the stage. The CEO of CAPG, Don Crane, CEO of the California Association of Public Hospitals, Erica Murray, CEO of LA Care, John Baackes, and the Director of San Diego County Health and Human Services Agency, Nick Macchione. Let's give them a round of applause. There you go. It's got your name on it. Thank you, everyone. I appreciate your participation and your flexibility. Some of you have been through this song and dance before. Some of you have not, so I appreciate it. Nick, I want to start with you. We met at our Los Angeles conference 2 years ago, and the second thing you said to me was, you got to bring this to San Diego. Why aren't you doing this in San Diego? And so we're here. Thank you for pushing us. Let me start with you and just sort of ask, sometimes we get kind of caught up in the day-to-day of healthcare, whether it's a Hep A breakout or trying to work with County Board of Supervisors. What are the kinds of things you're spending your mental energy on related to the future of health and human services in San Diego County, so that despite whatever happens in Washington, D.C. or Sacramento, reform and progress continue here in San Diego?
Yes, thank you. And first and foremost, welcome to San Diego for those that have traveled here. And we are very grateful, DJ, that you brought this fireside chat on health policy here down in San Diego, very importantly. What it's not, I will have to say just it's not I, but what we're very excited about in San Diego is the effort we have embarked on now almost approaching a decade, which was clearly in 2008, seeing and leading up to 2008, the conversation at that time between the senators of health reform. And knowing clearly it was going to really be about coverage and payment reform that was going to be happening at the federal level. But localism, because there is such a word, we know federalism, right, the play between state and feds, but localism, which is at the localities with the state, that we were going to be left with the service delivery reform. And we took that to heart to talk about taking a look at the mirror of how well we were operating. And I think we were quite proud in San Diego of the accomplishments we've been making about our delivery system. But what was missing in the mirror, in the reflection, was everyone else in the community. What we saw in our reflection was the usual hospital and clinics and academia and government and folks. We weren't seeing the reflection of our community. We weren't seeing the accountability of all. And we realized that it wasn't just about service delivery reform that we were after. That what we were after and what we wanted to leapfrog to was this concept of wellness, right? The thing that we all cherish, right? The state of health and safety and economic vitality. And if that's good enough for each one of us, we wanted that to be a goal for all 3.3 million San Diegans. So we embarked on this journey in this ecosystem of how do we create this accountable community where everyone has a role, and we can talk about collective impact, cross sectors, etc. But there's a African proverb that says to go fast, go alone, to go far, go together. We chose the latter. And it's been remarkable movement that's now become a social movement of how do we create, and we could talk more about, a wellness ecosystem that builds beyond just healthcare delivery, but housing and safety and academic and education and workforce, all the wonderful reforms they're doing. How do we bring them all together to really drive things like improved life expectancy and quality of life, right? Longer and happier, not shorter and grumpier, I think is the metric we were after, DJ. So that's kind of the journey we've been taking.
Yeah. Erica, let me sort of ask you to kind of build on that, because within the context of the 1115 waiver, a lot of the public hospitals, your members, are spending a lot of time thinking about this kind of challenge. How do we get outside our four walls and move upstream and and get a little more diverse in our wellness partners. Why don't you just sort of talk about what you're doing within that context, what your hospitals are doing within that context, moving upstream towards wellness like Nick discusses.
Sure, learning a lot from San Diego. Thank you for having me. Welcome, everybody. So the public hospitals that DJ speaks of are the 21 public healthcare systems across California. They are mostly county-owned and operated, but they also include the 5 University of California medical centers. And they are really the core of the healthcare safety net in California. They're just 21 systems, so they represent only 6% of all hospitals in California, but they provide about 40% of all hospital care to the remaining uninsured. On average, majority of patients in any public healthcare system are mostly Medi-Cal and uninsured. So you can imagine that the impact that the Affordable Care Act had on public healthcare systems. The other reason I call them public healthcare systems and not public hospitals is that they all have primary and specialty care clinics on their hospital campus, but also out in the community. So they might get confused with an FQHC, and some of them actually are FQHCs, they're just county-owned and operated. But they are systems of care that are trying to find ways to be more system-like. And back in 2008 and 9, when we were talking with the Schwarzenegger administration about the possibility of California leading the country in instituting universal coverage, and all the discussions about what role the counties and the localities should play with that, we imagined what the public healthcare systems needed to be doing for that effort. And it was really around wellness and the social determinants and keeping folks out of the hospital and to the most appropriate source of care possible. Building relationships with provider teams in primary care settings, reducing the wait times to see specialists, really understanding the complexity of their entire life situation, not just their medical conditions, bringing in physical, behavioral health together to treat a whole person. And that started us on a journey with the federal government, because localities like San Diego and other public institutions can provide that Medicaid or Medi-Cal match. So it started us with a partnership with the federal government to create performance-based programs that challenge these localities to provide better, more integrated, more whole person, patient-centered care. And we've been on that journey ever since. And now we have programs across the state called Whole Person Care that try to put the patient, who up to now has been coming into the emergency room multiple times a month, if not week, to understand why. What is going on for that individual that is creating that situation and those inefficiencies all across the system. And 9 times out of 10, it has to do with the intersection between physical and behavioral health and housing. So what can we do around those issues in particular to make sure that the patients are getting the care that they need and the system as a whole is working most efficiently? I think we just saw evidence today in the Los Angeles paper. They covered the fact that Housing for Health is saving 20 cents for every dollar that's invested in housing. Los Angeles County Department of Health Services is saving $1.20. So it makes economic sense, and it's the right thing to do. So there's certainly more work to do, but no matter what happens in Washington, we will continue on this journey.
Yeah. So John at LA Care, let me ask, do you feel like that the current Medicaid framework, the state plan and the waiver, does that allow a innovative, forward-looking Medi-Cal plan like LA Care to implement or integrate some of that learning around social determinants and housing? Do you feel like you've got enough flexibility, or do you feel constrained by maybe the lack of freedom out of Sacramento?
No, I would say for LA Care, we feel that we do have freedom, and I'm not going to waste a lot of time in Sacramento trying to change things. I want to do what I can in LA to advance things. So, for example, on the whole person waiver, which LA County is pursuing one, and we are linking housing and health there. LA Care has pledged $20 million over 5 years on the housing portion of this, which will provide permanent housing for 300 people who are otherwise uninsured. And I think our issue is that we understand there is a linkage, as Erica pointed out, between these things, and we think that all of the people we care for are living in poverty. So housing, nutrition, safety, education are all going to impact the cost of delivering health care to these folks. So we think it's incumbent that we identify those social determinants that are barriers to a better quality outcome or in a more economical spend of the healthcare dollars. So we're trying to find ways that we can use the current resources we have to at least identify those, and where we have the room to financially support it like we've done on the whole person care thing, we're going to do it. I mean, some of us would like to see the day where a care manager in a health plan that has people who have problems, that we can immediately get them into food stamps, we can get them into a housing program, that we can reach across the barriers and the silos and be a kind of a one-stop shop for our members to get to those things. Because, I mean, remember, if somebody's living in poverty, they don't have time necessarily to go and sign up for all these things on their own, much less know where to go. I think, given that we're custodians of public dollars, if we can add some intelligence to how we're spending those so that our spend goes down by investing in the other programs, that's what we're trying to do. And I don't need to go to Sacramento to do that right now.
Don, let me ask you about this time in reform and the progress of reform. Do you feel like, I mean, the cynic in me sort of says, gosh, I feel like we're coming to the end of the energy around reform, and the cynic in me says, we're sort of, that window of opportunity to change things may be closing. Do you see it the same way, you know, and certainly after the 1993-94 federal efforts, things were on pause for a generation, right? Are we entering a period of pause in reform, or do you think there's a little more like quiet, consistent movement towards change?
You know, well, first off, thank you for having me. Glad to be here. Done this before, and it's really fun. So, I mean, I think there's been a bit of a pause. So clearly, November 8 occurred, new administration. I think there was the expectation that the Affordable Care Act, et cetera, would continue a pace under Hillary, and that didn't happen. And subsequent to November 8th, Tom Price came and went. We now have a new HHS secretary. So there's definitely been uncertainty associated with all that change. That uncertainty has generated questions and comments about whether, you know, the movement from volume to value is going to continue at the same rate of speed, or faster rate of speed, slower rate of speed. So, you know, we're clearly watching all that with interest. I think there's been a little bit of appropriate level of, you know, pause to just see what the new HH secretary would do and so forth. But underneath it, and this is where I think the answer to your question lies, DJ, is the fire burning underneath health reform is burning just as hot as it ever did before, principally in the form of basically kind of runaway cost. No one has yet bent the trend particularly, right? Mm-hmm. So we're still at 18% GDP and on our way to 25% GDP and sky falling and so on. But so the imperative of reforming the system remains as high today as it ever did. We still, of course, have macro, right? Mm-hmm. Probably more significant than the Affordable Care Act in terms of delivery model reform, payment methodology reform. And we're in the middle of it. So we've got, you know, APMs and MIPS, and we're in 17 right now. I think we're still in 17, the first measurement year. We've got a new regulation that just came down that in fact brings in now the cost measure in 2018. So that kind of blueprint remains on the table and is being implemented, maybe not with the zeal of the former administration, but is still being implemented. And you know, we're watching physician groups all around the country meet those challenges, staff up, knowledge up, if there's such a word, and get ready for that. So a little bit of a pause, but it continues apace. And that's because underneath we've got to get to a more efficient and effective system. So it's happening.
Erica, I want to ask a similar question, but a little differently and specific to California. Do you think that because of the nature of the federal politics around healthcare and the energy perhaps of the 2018 gubernatorial election, do you think that looking ahead that really California needs to take some significant leadership as a state on health system reform, on health policy and funding, not just health policy, but health funding, so that, regardless of what happens in DC or in other states, California can and should lead? Do you think that's really an imperative, or do you think it has to happen within the broader context?
I do. I think that the dynamics of the gubernatorial election thus far have been around what California can do on its own in terms of coverage expansion. And so we have some candidates talking about a single payer model that suggests that the Affordable Care Act was always inadequate and insufficient, and we should scrap it and build an entirely new model from the ground up. And then in the middle there are opportunities to maintain and uphold what we have, but also identify the things that haven't happened yet. We still have 3 million remaining uninsured in California. Mm-hmm. So for those small states, that we have as many uninsured as state populations. And so there are major challenges that remain in California. There's also a vision and leadership that we're really hoping we can see out of the new governor in terms of what, with 1 in 3 people on Medi-Cal now in California, what should Medi-Cal look like? Yeah. How should we think of this program that is so much more than a program now? How can we use the program to keep people well in every sense of the word? And what would that mean for delivery systems? I think those are very important questions. And that's going to take leadership and financing and real dialogue. We are very lucky in California, I think, having worked on Capitol Hill before coming to California and seeing multiple states. We are very lucky in California that we tend to agree on the big ideas. We're not having an ideological battle the way other states might in terms of the role of government and our responsibilities to care for those most vulnerable. That is, we largely agree on that. Where we tend to quibble is around the how. And the how is very important in a state of this size with this many people on Medi-Cal and who remain uninsured.
Yeah. John, I don't know if you know of any counties that, as Erica referenced, do you know of any counties that would have a single payer, that would have a big health plan that might be able to take over everything?
Yes, I happen to know one.
Yeah? What do you think that might look like? I mean, speaking less comedically, LA Care has a unique footprint in the county. Where could we see opportunities for a more consolidated, a more unified purchasing model where LA Care's scale could really bring unique value to the system? We talked at one time, for instance, about some Medicare authority coming to the county. What do you think?
Well, on this single payer debate, I think anyone, if they were starting from scratch, would say, well, yeah, the single payer is the way to go, but we're not there. We have an infrastructure that's been developed, and I think the whole idea of saying, let's move to a single payer and dump everything is not going to happen. So I don't think that's really a practical question to consider. Right. I think is what role can a public plan like LA Care play to make the system more efficient? And we've already expanded out of Medi-Cal into the California Exchange. We're the only public plan in California that participates in the exchange because I think it's important for us to do that. So as people migrate out of Medi-Cal into an employment situation where they don't have health insurance, they can go to the exchange. And if we're there, they can have continuity of coverage and access to their providers. There's nothing to prevent us from extending that sort of foot-toe that we put in the water on commercial to say, well, why don't we offer coverage to employer groups as well? Mm-hmm. So I would rather see LA Care, if we're going to be of value, expand the access through LA Care for other people in the county, and we'll compete. And I think that's the point about a public plan and what some people are talking about in a public option. There's more transparency in a public plan than there is even in a not-for-profit plan. Our board meetings are open to the public. They're a circus. You should come sometime. They're very entertaining. We had a woman come and in her 3 minutes play a mandolin so that we would adopt music therapy as a covered benefit. Now, does that happen at your board meetings? So anyway, I think
see my board meetings.
Yeah, I know.
Crazy.
I think that's
Also
the
circus,
kind of thing that we're going to explore rather than conjure up how we would operate in a single payer system, because it may be it may have passed the Senate, it may be over in the Assembly now, but nobody's figured out how to pay for it. And the ideas, some of them that are floated around about, well, the state can adopt a tax and do this and that. Anything we would do in California to pay for that on our own would make California a less friendly place to do business, because business would say, well, the taxes are horrible, either on my business or for my employees. So I just don't see it as a practical solution anytime soon.
Yeah.
But I'd rather see us use the current infrastructure of 16 public plans we have in the state to say, does that provide us some competition that will help the goals of reducing costs and so forth?
So Nick, you've got a county, one of just two, I think, or certainly not many, that is open to any managed care organization that wants to take Medi-Cal beneficiaries. They can compete and fight it out. Do you think that allows San Diego to be more innovative and progressive that because we have multiple plans? Or do you look at the plans and say, you know, you're not progressive enough. You're still just kind of doing the same thing that plans do. You're a technology firm, you move money around, but you're not really getting at mental health, behavioral health, upstream.
Yeah.
What do you think?
Well, let me give you an example to illustrate the importance of innovation, and I think you hit on it for us. We're a geographic managed care. We have 6 plans. Soon we'll have a 7th plan. Aetna and CVS will be coming to San Diego. And that's a motley crew of plans. But for the last 2 decades, our Medicaid managed care plans come and meet on a regular basis. We describe it as co-opetition. You have competitors collaborating at the table. We do this with our hospitals. We really describe our marketplace as co-opetition. And the whole person wellness, we don't call it whole person care in San Diego, but our pilot, whole person wellness from the 115 Medicaid waiver, a testing point about how innovative our plans were they really going to step up, doing together on our coordinated care, if you will, of the frequent utilizers, in generating savings to go to supportive housing. And this was a tough one. I mean, and I know some of my colleagues are here, and I could see them nodding. But unanimously, they all approved and agreed that this is where the need is. And we've talked about housing quite a bit here, right? No housing, no health. We get that equation. How do you then demonstrate that? This is supportive housing now, not actual housing. But to me, it was a very positive step and a very challenging dynamics with multiple viewpoints. The co-opetition model has brought out innovation from the different plans. Are we there yet? Living longer and happier? No. We have 975,000 people on Medi-Cal in San Diego, about 1/3 of our county population. But I have seen that being at the table and coming on a regular basis where they have embraced public health, where they have embraced behavioral health. I know George Scaleri is here, the Community Health Group. He's one of our champions, among others, who have embraced housing. They've embraced the principles. We have some of our plans that become Live Well partners, where health, safety, and the thriving components come together and embrace those principles. That is cutting edge. And it's not just the words, it's the deeds of how we're looking at improving their covered lives in a very holistic way. So it's not easy. It's more chances of hurting cats. but we think it's brought out the best in of us in San Diego. And we haven't been waiting for DC to give us edicts. To your point, DJ, is how do we innovate locally, continually? And I think it's been, even already hitting on this panel, is that the answers are not going to come from, in my opinion, clearly not going to come at the federal level. It's going to be at the state levels and local levels. And I think even more at the local level. And it's the discoveries from within events like this where we're, I'd love to know how many, if we did a poll, how many people know their housing authority? Okay, not many hands. You need to. They are a key ingredient of what we've been talking about for health. So there's yet for us to develop that ecosystem at the local level that will not only drive and better manage costs, but more importantly for me, as the public health guy, improve lives.
Yeah. So Don, let me ask you, your members at CAPG, are you in all 50 states now?
45.
We can round up to 50, right?
Yeah.
You're now national. You certainly are based and born in California, but got an office in DC now, and your groups are generally physician-led, right? Some hospitals, but they're generally speaking taking risk or in some sort of value-based payment methodology. And I would bet, if we're all honest here, right? A lot of health plans, a lot of provider groups, a lot of hospitals still don't really have the infrastructure, the technology, the tools, the awareness in place to even really start talking about quality on something like supportive housing. Or it's very difficult to talk about and put meat around the bones of some of these social determinants. But yet your groups are some of the more innovative and value-based, and they put their money where their mouth is in the whole country. How do we get the groups that want to be innovative, that want to put their money where their mouth is, how do we get them the tools when they're, in many cases, they're swimming in it as it is, right? How do we get them down the pathway towards a deeper level of innovation in this post-ACA world without totally burning them all out?
Well, so that's what keeps me up at night. That's what CAPG is in the process of trying to do.
He calls me. That's why I know to ask this question. Don, it's 2 in the morning. What are you doing?
Because here we sit, we're lucky around CAPG and lucky here in California because we have so many sophisticated multi-specialty medical groups and IPAs that have had experience with capitation, professional risk, institutional risk, full risk for decades, right? So this is really the sort of fertile crescent of where the know-how of coordinated care resides. And so, we're careful the way we say this because when we're in, Georgia and Florida and elsewhere, if you sound like, you're snooty and superior coming from California, boy, they really don't like it. So, but we're in the business of trying to help export the California know-how through the sharing of best practices across our members. So we have meetings everywhere and conferences and materials and programs and so on. Some others are trying to do it too. Clearly, CMS is doing it through the land. So there are efforts underway across the country, and other medical societies are doing so. But they are fledgling, they are nascent. There's a lot to be done. It's just a lot just to take, say, maybe professional cap, let alone all of a sudden take, institutional cap, let alone starting to take responsibility for social determinants where we know so much low-hanging fruit sits. So there is a long ways to go. I would love to see government put its thumb much, much more heavily on the scale to support this kind of transformation with a variety of incentives and so on. Presently, we aren't paid, for example, to do much in the way of social determinants. Typically, most of my members, it's not on their side of the DOFR. It's not within their capitation to take care of transportation and food support. Some do it where they can on their own nickel, using sometimes their own foundations. There's the recognition that this is where we need to go, but it's very early stage. So I think it's a question now of people seeing the need to move into risk-based contracting, which they do, and are starting the baby steps to get there. There is the Medicare Shared Savings Program, flawed though it is. It has made a difference. It is ushering in some of the know-how, some of the culture, some of the technology. You see people moving up and evolving up towards next-gen ACOs and so forth. People are in bundled payments. So it's happening. But, while we'd love to have it all happen by, say, next March 11th or something, it's probably going to take, 2 decades or something like that. It's a real paradigm shift, and it's underway.
So let me ask you a question, Don, follow up, connecting some of these dots around the CenterMed story that came out recently. CenterMed is an entity that provides administrative and managed services for IPAs, for physician groups. Came out last week that they have had some findings that were not.
It's called fraud.
They maybe have committed fraud. Anyway, they're closing down, and DMHC is running an investigation. I think others are going to investigate. I think there are 800,000 lives that were mentioned. On the one hand, I'm already hearing conversations today that experience is engendering a conversation about how do we regulate these subcapitated entities at the state level, these RBOs, your members. How do we get in their business so we can better prevent stuff like this from happening, on the one hand, A. B, that might seem like a normal trade-off for adding the thumb to some of this, the social determinants work, that if we are going to be able to move in a way that continues to empower physicians close to the community, but also gives them more responsibility, that it's going to take a lot more regulation. How do you see that CenterMed story fit within this context of us all trying to move the ball forward?
So, the short answer is I don't know.
Yeah.
The longer answer is we're watching and learning as we go. So CenterMed is an MSO, manages a lot of lives through a lot of IPAs, almost all in Medi-Cal, CAPG member, and they have been found to have antedated a fair number of claims and so forth, which has created problems associated with appeals and the like, and it's being investigated. John will know a lot more about the particulars than I do. The one good thing is, I'll say, it's very rare. So we have not had this particular kind of experience ever in my own experience around CAPG, nor have we even had insolvency. So the problems associated with managed care, early managed care era, as in 1980s, have largely disappeared. So maybe the good news is this is a very rare kind of a case. Nonetheless, it is a black eye, clearly through the delegated models where plans use groups and MSOs to deliver services, pay claims, do credentialing, and do all that kind of thing that has worked so well in the main. So it's a black eye, and it will give rise probably to calls for regulation. And, what do we think about regulation? Ordinarily, businesses of any sort in any industry don't love regulation, right? But it's probably a two-edged sword. I mean, if the regulation also came with, better sort of recognition and incentives and the kind of transformation that we've been talking about, that's something we would probably be willing to talk about and countenance potentially.
Yeah.
And we haven't seen it yet. I don't know where that stands exactly, but we're ready to engage in the conversation.
So John, let me ask you as an important plan voice, and you've got a number of IPAs that contract with you. I know you have told me you have started direct contracting, you're moving more to a direct contracting model. What else, let's say that there's an active conversation about regulating risk-based organizations and these subcapitated entities. What can plans bring to the table? So it's not a punitive conversation, but rather a more holistic one where plans can say, yeah, you're going to get more heavily regulated physicians, but we're going to contribute this to the broader success.
Well, I think health plans in California, and I realize that this has developed over decades, and I'm a relative newcomer to California, but I think that the plans going to delegation and the groups wanting to take on more risk through dual and full and all that sort of thing, we also delegated away to the groups some of the functions of the health plan. So if we have 58 delegated entities in LA Care for 2,130,000 lives. If you do the math, the average risk pool of these delegated entities is about 37 or 38,000. That's way too small a risk pool to operate a really efficient health plan. And then they have the burden of trying to invest in the technology, as Don said, so they can do all of these things. And so they don't, so they go to an MSO who re-aggregates the lives under the IPAs, the medical groups. And CenterMed, as an example, had 1.2 million lives, so they had the resources to invest in the technology. What I think we're doing at LA Care is saying, look, the health plan should take on that responsibility, which health plans do in the 49 other states, so it's not unheard of. Because at 2.1 million lives, we could do the administrative services. The medical groups can still have the financial risk because it's beneficial for them to have it and for them to invest and do certain things. But I think we have to create a better environment for those medical groups to thrive so they don't have to depend on these sub-delegated entities who are regulated by no one. The MSOs are regulated by no one. So the one throat to choke for the regulators are the health plans. So we're the ones that are going to bear the brunt of, oh my God, you let this happen on your watch, we're going to have to impose new regulations on you. So we're going to have a very serious discussion with the regulators about going forward. If you're going to put more regulations on us, then we're going to need some trade-offs, as Don was mentioning before. We have started a direct network mainly because the size of LA Care doubled since the Affordable Care Act. And LA County is a huge county, 10 million lives spread over how many, 4,000 square miles or something. And there were pockets of the county where we just did not have enough providers. And we were able to go recruit providers outside of the medical groups to directly contract with us so we could fill some of those holes. And we will continue to do that as long as there are people willing and interested in that as an option, because it creates another opportunity for participation in Medi-Cal for those doctors, and I think it does a benefit to our members by giving them more access.
These risk-bearing entities or organizations are, generally speaking, not regulated at all by the state.
Well, RBOs are regulated by the state, but it's a very light regulation, mostly around financial solvency.
Right.
It's not about administrative efficiency or competency or any of those issues.
You think it should deepen and broaden?
Well, I would be a person who would, Don will probably kill me, but I would suggest that we require the medical groups to be certified or accredited, because that's essentially what we're doing in our oversight. And I think if they went out and invested in that accreditation or certification process, it would give more assurance to the regulators that we are watching the store and we are asking for accountability.
Nick, let me ask you, as you're not in that direct sort of Medi-Cal financing stream on the physical health side. You do a lot in medical or mental health and substance abuse, and you're an active purchaser, perhaps more so than any other county. You talked about getting the MCOs together and the provider groups, or the hospitals in particular. How do you hold them accountable? Maybe what role do you see as for you as San Diego County to hold the health system broadly accountable to some basic standards?
So we, of our $2 billion budget for Health and Human Services, we contract about $530 million of that. So about a quarter of that's budgeted. And that's primarily with everywhere from some of our hospitals, but our FQHCs and other nonprofit organizations across the gamut of Health and Human Services. So whether we're talking about in public health or behavioral health or human services or housing, the mindset for us is really our whole procurement strategy from the beginning. And I think first, so I think I'm the only government person up here, primarily really government. I'm one of the good regulators. I will say we're more regulated by the state government, so I can relate. I really can relate to you. For us, it's been a conscious effort because we contract such a large amount. It is the procurements and knowing what it is we're asking in the deliverables. Today, percent to total of our $525 million spend annually, about 85% of that, thereabouts, is cost reimbursement. Mm-hmm. We consciously want to flip that. We want to go to pay for performance. What we hear from our contractors is the extensive laborious regulations that take away from the ability of putting in time for service. And we've been consciously moving slowly and guardedly, of course, but moving into that arena about trying to, as procurements come up, as contracts come up, multiple year contracts, is shifting them into pay for performance. We have to do a better job in government of asking what it is of our contractors, and we call them our business partners, by the way, and ensuring we're realistic, because more often than not, we're underfunding in a lot of the requirements we had. So we've had great success. To give you an idea, we have 325 different contractors, primarily nonprofits. We have a few for-profits. I have 2 contractors on the at-risk list. It's because of the active engagement of not only the procurement cycle, but once they have the contract, how are we serving as partners? Are we just washing our hands and say deliver and go conquest, or are we staying with them? And that's been our process, our kind of secret ingredient to the marinara sauce, if you will, that we have stayed as a partner from the programmatic, the contract side, with that business partner. So as they're dealing with issues, much early on, we can address. And therefore, getting better outcomes as a result of it.
I should just say that you've been the head of the county agency for 20 years.
10 years. Well, 20 years in the Health and Human Services since inception, almost about approaching 10 years as the agency director.
Yeah. What, I mean, this is just between you, me, and the walls. What do you want to do next?
DJ, I just want to survive the next day. You know, this is a phenomenal community, and I think we'd all agree. There's so much work to be done, and it's so gratifying being part of this nation state. That is the 7th largest economy in the world. We should not forget that. I think we're surpassing France soon. We have an extraordinary opportunity to showcase single payer and whatever modeling, but to showcase as a nation state how we can truly, I want to help be part of, with all my colleagues here, writing the sequel to the IOM report in 2013 of Shorter Lives, Poorer Health. That California writes the sequel to that IOM, now National Academy of Science report, of Longer Lives, Better Health. And that's the quest. That's what excites me. That's what I want to be doing. That's what I'm hoping with my great team and folks and partners on the track to do.
Erica, I'll ask you first the question I'll ask everybody to close, which is, what advice would you give to the folks who are in the room, who are on our email list that we're going to send this out to by video, they're going to see it on some of our California public access television partners. What advice do you give to healthcare leaders and advocates about how to navigate this time of uncertainty?
Well, I think we cannot give up the fight in terms of protecting the gains that we've made in California. As much as it's easy, we have geographic distance, so we can just sort of stay out here and focus on the work we have here, and there's plenty to do. We cannot ignore the enormous threat that we've managed to avoid this year, although I would argue a year ago, it certainly didn't seem like we were going to. And the way that a repeal and replace effort was avoided was certainly unpredictable. It could not have been a more dramatic or unpredictable and anxious year for those of us who are trying to defend the incredible gains. And a lot of the conversations that we had with our elected officials were very troubling, I think, in reminding them that 1 in 3 people in California are now on Medi-Cal, and receiving responses that weren't in these exact words, but left me feeling like they thought, yes, that's the problem. And that there's just a fundamental ideological difference of opinion in terms of how low-income people should receive coverage. The reality, though, is that millions of people are working, and most people on Medi-Cal and newly covered come from families where somebody is working. And so it is not a function of these able-bodied adults who are simply taking advantage of a system. It really is the economic structure we have in place and the realities of living in poverty. And that millions and millions of Californians do that while working. And so I think that even as we live in this uncertain time and I think we still need to think creatively and innovatively around how to be more patient-centered, improve the delivery system. I think that has to be more continued thought about how to continue to marry delivery system reform with payment reform, and to take these ideas of accountability even further and combine our shared thinking, knowledge, and expertise around true population health. We can't stop those conversations. They're absolutely critical to where California needs to go while we continue to educate our elected officials in Washington about the need to maintain this critical foundation we have.
Good. Don, what advice or counsel would you give to our audience here today about how to navigate this time of uncertainty?
Keep up the good work you're doing in the movement from volume to value. I mean, 30% of the spend is on waste, right? We know that from repeated studies. It's duplicative and unnecessary care and avoidable care and the like. That 30% represents a good profit margin for those that are in risk-based models, right? So there's perhaps a selfish interest there. But if we rationalized our system and we were able to get rid of most or all of that quote-unquote waste, we'd have more than enough money to cover all of the uninsured and to otherwise right the healthcare ship that we're on. So I would continue that work. And then I think a final word, remembering also what we're doing here, which is transforming our system to meet the disease burden of our population. I mean, so 90% of the spend among seniors is chronic disease. 75% of the spend on the population generally is chronic disease. That was not the case in the first half of the century when our systems and our hospitals and our relationships and our patchwork system was developed. So we're really having to retransform this entire system to make ready for this highly diseased population that we are keeping healthy much longer. So the burden is going to do nothing but grow, and we need a delivery model that it's ready, that's able to handle that disease burden, and it's going to be one that's going to be transformed in terms of the way people are paid, the way they work together, the way we use physicians and non-physicians. All that has to match the needs of the population. So the task is huge, but the rewards will be even bigger. Mm-hmm. So that's what I would say.
Very good. John?
I make this short. I would build on everything Erica said, because to me the issue is nobody is asking why the hell are 14 million people in California on Medi-Cal? Why can 14 million people demonstrate that they earn less than $16,240 per person as an individual, or $24,000 as a family of four? That's horrible. And the tax bill that was passed Saturday night is not going to do a damn thing to improve that. So I think the bigger question we need to ask, we can certainly do all the reform within, but what are we doing socially about moving people out of poverty? I can't do it as a health plan alone. I need a larger societal answer to that, and that is more important to me than some of the details that we get tied up in every day. We've got to move people out of poverty.
There's a reason you're one of my favorite people.
I know.
I'm sorry to put you in the shoes and have to follow that, Nick, but what counsel would you offer?
Ditto, absolutely. But so our challenge, we're moving from sick care to health, but it's to wellness. And so we need a unified vision that's not polarizing. We have polarity in much of the conversation we have here. We have a Republican perspective, we have a Democratic perspective, we have a very polarized federal government. Is how do we reunite as a nation? And maybe this is the Don Quixote in us, but we need a unified vision, an inclusive vision that achieves the inclusive economy. And I really believe that we are at a point in California of defining that, showcasing that, and begin to really model that next year, DJ, when you come and have this great forum here in San Diego, that we don't bring the same audience. It's all of you plus one. But the plus one would be the folks that are in employment. The plus one would be the housing authority. The plus one is your fire chief, police chief. Plus one could be a legislator. That we bring others to help connect the unconnected to what it is we're doing so they could better understand this social movement we're doing around wellness.
Awesome. Nick Macchione, the Director of the Health and Human Services Agency at San Diego County. John Baackes, the CEO of LA Care. Don Crane, CEO of CAPG. Erica Murray, CEO of California Association of Public Hospitals. Let's give them all a round of applause.